First of all, let's examine the contents of this presentation. We begin with important definitions of thrombosis, then study the composition of thrombi and predisposing factors to thrombosis. The types of thrombi are then examined, and we look at the outcomes of thrombosis. Finally, we individually study arterial, cardiac, and venous thrombosis. First of all, the important definition, the definition of thrombosis. A thrombus is a solid mass of blood constituents formed within the vascular system in life. Note that thrombosis is quite different from clot or coagulation. Clotting means coagulation, and this can occur within or out with the vascular system in life or post-mortem. Thus, if I pour some blood into a dish, it will clot, and that is not thrombosis because it's out with the vascular system. Similarly, I can find blood clot in blood vessels at post-mortem. This is not thrombosis, this is coagulation or clotting. The commonest clinical syndromes which result from thrombosis are first of all myocardial infarction, which we abbreviate to MI, which results from thrombosis in the coronary arteries. The second common clinical syndrome is pulmonary embolism, which results from thrombosis in deep leg veins. Here's one example of the results of thrombosis, which is myocardial infarction. We will deal with this in greater detail later in the presentation on ischemia and infarction. The infarct is the thinned yellow zone at the top of your screen. The normal myocardium is shown at the bottom of the screen. The thinned yellow myocardial infarct is surrounded by a distinctive hyperemic border. This infarct is at least 2 weeks old.
Let's see what are the compositions of thrombosis. First one is fibrin, polymers on top, and second one is platelets. It is very tiny, shown in lower compared with RBC, red blood cells. Then third one is entrapped RBCs and serum.
First of all, fibrin. Fibrin is produced as a result of conversion of fibrinogen to the polymer fibrin by activation of the coagulation cascade. This might result from contact with damaged endothelium or perhaps atheromatous plaque contents. The coagulation cascade is therefore triggered, and fibrinogen is converted from the soluble molecule into polymerized jelly-like fibrin. Platelets are small particles derived from megakaryocytes in the bone marrow. They don't have a nucleus. They contain alpha granules, which are adhesion substances which promote adhesion of platelets when released, and dense granules, which are contain aggregation substances which promote aggregation of platelets. Platelet aggregation is in fact a normal phenomenon and occurs continuously in the body to repair minor endothelial injury. In excess, a mass is formed with possible pathological consequences, and this is where we use the term thrombosis. What promotes thrombosis? Well, one way to look upon this is the classic view of Virchow, who derived Virchow's triad. The factors which promote thrombosis can be found, he said, in the blood vessel wall, or be concerned with the flow of blood or with the constituents of blood. These three factors are known as Virchow's triad, and we'll cover examples of that when we examine the different types of thrombosis at different sites later on. What types of thrombi do we recognize? Thrombi can occlude a vessel, and this is the upper diagram that you're viewing now, and this may result in necrosis of the parts served. Secondly, thrombus can form in the wall of a blood vessel, and occasionally, rarely, this can release little fragments. This is known as embolism. These fragments can travel in the bloodstream to block distal vessels. Finally, thrombus on the heart valves due to infection can also embolize. These types of thrombi are known as vegetations, and they usually form on damaged valves, valves which are damaged either by previous inflammation due to rheumatic fever or chronic degenerative change of old age. This is the clinical syndrome known as infective endocarditis. What are the outcomes of thrombosis? First of all, thrombolysis can occur. If you examine the diagram, you can see a thrombosed vessel at the middle top of the diagram, and the outcomes are disposed around this. Thrombolysis is the first and desirable outcome. Plasminogen activator released from the wall of the vessel from the endothelial cells converts plasminogen entrapped within the thrombus into plasmin, which dissolves the fibrin. We do attempt to promote thrombolysis by administration of thrombolytic agents in the early stages of coronary thrombosis in an attempt to prevent myocardial infarction. The second possible outcome of thrombosis is recanalization. In this process, endothelial cells grow out from the wall of the vessel and form vascular channels which pass through the thrombus from one side to the other. Thus, some restoration of blood flow can be established. A further possible outcome in thrombosis is embolism. This is shown on the lower right of the diagram, and you can see a small piece of thrombus breaking off and embolizing to occlude distal vessels. The final possible outcome of thrombosis is fibrosis, otherwise known as organization. In this process, fibroblasts migrate from the wall of the vessel into the thrombus and produce collagen. The vessel is thus plugged by fibrous tissue, and no blood can then pass through the vessel. We'll now consider thrombosis in arteries, in the cardiac valves and chambers, and in veins. We've already seen how the factors which promote thrombosis in vessels can be considered under Virchow's triad. Changes in the wall of the vessel, changes in the flow of blood, and changes in constituents of the blood can all promote thrombosis. If we think specifically about arteries, then changes in the wall which can promote thrombosis are atheroma, by far the commonest predisposing factor, and also the rare condition vasculitis, which means inflammation of the wall of a vessel. Atheroma also alters the flow of blood, and this can make some contribution towards a tendency to thrombosis. And finally, if we consider constituents of blood, one example here is smoking. Smokers have sticky platelets which are much more likely to promote thrombosis. Let's now consider the appearance or morphology of arterial thrombosis. Thrombosis in arteries commences with adherence and aggregation of platelets. In the diagram, we show platelets adhering to an ulcerated atheromatous plaque. A mass of fibrin, platelets, and blood constituents is then laid down over the initial aggregation of platelets on the plaque. Thrombosis can lead to vascular occlusion, resulting in, for example, myocardial infarction if a coronary artery is occluded. The picture here shows a coronary artery cut in cross-section. The lumen of the artery is occupied by thrombus, indicated by the light mauve arrow. You can also see the yellow deposits of fat in an atheromatous plaque, indicated by the yellow arrow. Other possible outcomes of arterial occlusion due to thrombosis are gangrene of the leg or cerebral infarction. We now move on to consider thrombosis of the cardiac valves and chambers. This is quite different from coronary artery thrombosis, thrombosis in the artery serving the myocardium, which we've just been examining. If we consider the etiology of cardiac thrombosis first of all, we can once again first begin with Virchow's triad. Factors in the wall which can promote thrombosis in the cardiac chambers include myocardial infarction and infection of the wall. Infection occurs most commonly in the valves and is known as infective endocarditis. A factor affecting flow in the cardiac chambers is the dysrhythmia known as atrial fibrillation. This dysrhythmia causes blood to stagnate within the atria, and this stagnation promotes a tendency to thrombosis. This slide illustrates the three commonest sites of thrombosis in the cardiac valves and chambers. First of all, and illustrated in the lower part of the diagram, is a myocardial infarct affecting the wall of the left ventricle. This presents an abnormal surface to the flowing blood, and you can see thrombus have formed over the infarct. Occasionally, pieces of this thrombus will break off, indicated by the arrow pointing into the chamber of the left ventricle. Moving up the diagram, we can see thrombus developing on the cardiac valves. The particular valve involved here is the mitral valve, and once again little pieces of thrombus can break off and embolize, giving the typical clinical features of vegetations on the cardiac valves. The commonest cause of thrombotic vegetations on the cardiac valves is infection in the condition known as infective endocarditis. Finally, moving to the top of the diagram, you can see thrombus in the wall of the left atrium, and this has been caused or promoted by atrial fibrillation, so that there's stagnation of blood and a tendency to thrombus formation. Note once again on this slide the three common sites of thrombosis in the cardiac valves and chambers. As we've already noted, small pieces of thrombosis in the cardiac valves and chambers can break off and travel in the systemic circulation. These emboli, as they're called, or thromboemboli to be more precise, can lodge in distal vessels, occlude them, and result in infarction of the part served. An example might be a cerebral infarct, where a small piece of thrombus breaks off and occludes a cerebral artery. Finally, we move on to consider thrombosis in veins. Once again, we can employ Virchow's triad to consider factors which promote thrombosis in veins. The most important site of venous thrombosis is in the deep veins of the leg. Changes in both the wall, the flow, and constituents of the blood can promote thrombosis in veins. Let's consider the wall of the vessel first of all. It is well established that careless patient transfer in the operating theatre can damage the endothelium of valves in the veins and lead to an increased risk of deep venous thrombosis. Next, let's consider changes in the constituents of the blood. After operations, injury, or severe illness of many kinds, fibrinogen and other coagulation factors in the blood are increased due to increased hepatic synthesis of these factors. This leads to an increased risk of venous thrombosis, in particular a risk of thrombosis in the deep veins of the leg. In the case of surgery, in certain circumstances, heparin is given to patients to reduce the incidence of this potentially fatal complication of operations. The final arm of Virchow's triad, which we can use to consider factors which promote venous thrombosis, addresses changes in flow of the blood. Slow blood flow, promoted for example by immobility due to chronic illness or bed rest post-operatively, can contribute to development of venous thrombosis. Having looked at Virchow's triad and venous thrombosis, let's now have a look at a list of predisposing factors and conditions for the development of deep vein thrombosis. First of all, immobility, such as prolonged bed rest, which causes sluggish flow in the veins. Then, after an operation, or indeed after any serious episode of trauma, the liver secretes substances into the blood which increase its coagulability and promote thrombosis. Pregnancy is associated with a tiny increase in incidence of deep vein thrombosis in young women. In certain susceptible individuals, deep vein thrombosis can be promoted by certain types of oral contraceptive pill. Patients who've had severe burns and trauma are subject to deep vein thrombosis, possibly due to release of thrombotic substances from the site of injury. In cardiac failure, the general circulation is sluggish and there is a tendency to deep vein thrombosis. And it's well known that in disseminated malignancy, a common terminal event is pulmonary embolism from a deep vein thrombus. And finally, the entity economy class syndrome. This is related to item number 1, immobility, and it has been proposed, as many of you will know, that prolonged immobility in cramped conditions, and perhaps with an element of dehydration during long-haul air flights, is responsible for promoting deep vein thrombosis. This is currently the subject of investigations. Next, morphology of venous thrombosis. Deep vein thrombi, when we examine them at post-mortem, sometimes show alternating pale and dark zones, as shown in my diagram. This occurs by a mechanism which is illustrated on the right. The diagram shows a large deep vein going from the top to the bottom of the picture, and branches from entering the vein on the right. Consider the red arrow where blood is flowing from the branch into the main vein. You can see formation of a platelet-rich zone of thrombus indicated by the green arrow. This platelet-rich zone is pale and gradually builds up and will eventually occlude the branch entering the main vein. Thus we have a pale area created, and once the flow from the branch is plugged, then very rapidly the stagnant blood leading up to the next branch undergoes thrombosis, and that happens instantly, and so is platelet poor. The reason that platelets build up in the plug indicated by the green arrow is that blood is flowing by and platelets are gradually building up. Let's now consider the clinical aspects of deep vein thrombosis. Very often patients with deep vein thrombosis are asymptomatic, but sometimes the patient will complain of pain and swelling of the leg. In the event of pulmonary embolism, which is a potentially fatal complication of deep vein thrombosis, there may be chest pain and perhaps coughing of blood due to pulmonary infarction. Here we present a diagram of thrombosis developing in the deep veins. The veins involved are the deep veins of the calf, the femoral vein, and the iliac veins. The problem with deep vein thrombosis is that the thrombus can break off in the veins and travel through the vena cava, indicated by the black arrow in this diagram, ending up in the lungs. Here we have an animation indicating formation of thrombus in the deep veins of the calf. A small embolus breaks off and passes up the vena cava. The embolus then passes through the right side of the heart to the pulmonary artery and lodges in a branch of the pulmonary artery. In this particular example, pulmonary infarction results from lodging of the embolus in the pulmonary artery. A much rarer source of pulmonary thromboemboli is the right atrium. Thrombus can develop in the right atrium in the wall of the atrium. This is mural thrombosis in atrial fibrillation. This is a dysrhythmia where the atrium, instead of contracting with each beat of the heart, goes into a continuous quivering motion. This abnormality of blood flow promotes mural thrombosis. Here we have a photograph of an embolus lodged in a pulmonary artery from a deep vein thrombosis. You can see how the thrombus is coiled, and if you look on the surface you can see a pale line running along it, which is an appearance we've already discussed. Prevention of deep venous thrombosis is discussed in the next presentation. Here we have a closer view of the thrombus occluding the pulmonary artery, and obviously in this case resulting in death.